I was given the task of a case of transcatheter mitral therapy, so I was going to try to pick something informative and something helpful. So, we've had a lot of discussion about MitraClip, and there are MitraClip cases, and then there are those really tough MitraClip cases. So when you get these really tough MitraClip cases, there's some common themes. There's focal calcium that gets in the way sometimes. There's severe annular calcification, degeneration. There's, in addition to that, you can have these bileaflet, Barlow's, multiple segmented valves with commissural MRs, and all of them can be challenging, but you can put clips in there. And you do put the clips in there, you get great grasp, and you high five, and then you see that there's kind of residual leaks coming from in between the clips, or in the case of the commissures on the sides. This is from one day we were doing an animal lab working with a device, and this is just in a porcine model. Even in humans, you can have these profound clefts that come together and within the commissures, and it's hard to kind of approximate all that tissue, especially when you're clipping. And so there has been a lot of interest and a lot of publications with the use of ADOs and AVPs. Paul edited a textbook not too long ago, and there was a series of these type of cases that were published in it. There's pros and cons to kind of using both of these. I'll tell you what our strategy usually is. There is some data behind it. This was published from Seibel, in case N of 9. And of course, everything was fantastic, great results. There was one RCA embolization, but almost everybody had great MR reduction. So here's a case, a patient with severe mitral insufficiency. There is some mitral annular calcification, but the leaflet is free underneath it, and we could still grab it. And here you see the 3D transesophageal echo. So there is a cleft there, kind of hanging out in between P2, P3. And again, remind you that these clefts can be pretty dangerous at sometimes when you're talking about bringing devices in. So our plan was to put the first clip there, second clip kind of straddling the cleft a little bit, and kind of assess residual MR. So here's our first clip, goes in on the medial side. Our second clip goes in to the lateral side of that cleft, and we had a pretty good result. But then there's this IntraClip MR. We can debate about exactly what that is. It measured about 0.5 by 0.5 by transesophageal echo. We did a 3D assessment as well, and ultimately we put in a 10 millimeter AVP. I kind of like the AVPs because it has a larger waist, and so it really occupies a space in between the two clips. We don't take the guide out. We just insert a 6 French sheath in right at the end of the guide, and through that you can take a very long 110 cm 6 French MPA guide. Generally, you kind of snake a glide wire in between the clips, then you advance your guide across, you kind of unsheath the distal retention disc, and you pull back and you deploy such that that middle waist sits right in between the two clips, and then you deploy the more proximal disc. And with that, patients have, especially with these small IntraClip MR jets, they have pretty reasonable results. So first we put the two clips in, patient had residual MR 2 to 3 plus, we placed the AVP 1 plus, and then a pretty profound hemodynamic result. And clinically the patient did pretty well on follow-up as well. So, it allows for treatment of residual MR when you talk about these occluder therapies. However, there are risks, embolization, hemolysis, leaflet erosion. And the technique, again, I think a lot of people do it differently. So there is no standardization on which devices to use, how to size, and where to go. But again, it's a very difficult topic to study in a systematic manner. So these small interclips are successful. When you start heading to the commissures, it can be a little bit more challenging. And this is a case that we struggled with quite a bit, but I thought I'd show it to you. And from taking a note from Samir Ghafoor, you kind of learn from your mistakes and your failures, and this is one such case. So this is a 68-year-old male. He's got pretty profound connective tissue disease. He's had endocarditis in the past, P1 prolapse. So about 3 years ago, we had clipped him and placed 2 clips, and there was an area in between the 2 clips that we couldn't really grasp. The posterior tissue was pretty degenerated. And we couldn't really grasp it. And so we put 1 clip in, a little bit kind of central, second clip in laterally, and then when he came back with the recurrent symptoms, he had MR originating from just in between the 2 clips, and then he had commissural MR as well. But now, with the initial 2 clips that we had put in, there was a tissue bridge. There was a tissue bridge, and it had kind of fibrosed a little bit, and so we actually felt like there was a little more that we could grab onto. So we put a 3rd clip in between those first 2 clips, but now we had all this commissural MR. So how do you treat the commissural MR? And again, the commissural MR, he really had almost no posterior leaflet, nothing in the posterior segment to grab onto, and so we were a little worried about trying to place a clip in there, worried about SLDAs. So we thought we'd try an occluder-based therapy. So again, we got our glide wire across, torque fuse sheath, comes across as well. And initially, we sized it to about 8-9 millimeters, and so we put in a 12-meter muscular VSD occluder. We thought it had a big waist, and so it would sit in there, but this one popped right back out. And so ultimately, we put in a larger device, and we put that larger, same muscular VSD. It looks pretty stable. We had a pretty good MR result. So we start packing things up, start securing the groin, and usually our cardiac imaging person has left the room by this point, and then the anesthesiologist is still fumbling around a little bit with a TE probe, and he says, and it's never good when he says, "I think there's a problem," and so that was a problem. So the VSD occluder fortunately was circulating around, but then as we're starting getting things ready to see if we can tackle that, it starts flying out of the heart. For probably fortunate reasons. Steve Yakuba presented a case where there was a watchman, circling around the LA, and then fortunately for him too, it kind of popped out of the LA and went into the abdominal aorta. So we snared it. We used an end snare, and this was Subhash Banerjee's point, is you get that sheath right up to it. Don't drag devices through the aorta. You could cause a lot of injury. So you snare it, get the sheath right up to it, and then you want to pull it directly into the sheath. Unfortunately, and there's a lot of, I can't describe the satisfaction when you snare something out of somebody's body. So we ended up doing that, and really satisfying. And then we went back right there and then put a 18 millimeter ASO. And you see this, the video's kind of frozen here, but you saw that little bounce. It wasn't the greatest thing. We weren't really happy with it, but we thought, it's secure, and there's a lot of turbulence right at the level of the left ventricle in retrospect, but there wasn't a lot of MR. Hemodynamically, he looked like he was doing a lot better, but we paid the price for that because the following day, he had massive hemolysis, he had kidney injury, and as a result of that, we brought him back. That same next day, we ended up kind of snaring it, and you can see how deformed that ventricular side of that septal occluder is, and we were able to easily kind of snare it out and extract it from the body. And again, it just was very shredded-looking device. It didn't do well at all. There's now some interesting stuff coming out. I think Seibel for sure. I think Paul also, and now Mo Al-Kuli has also published a case where he actually put in a cardioform. And the thought is that with the Amplatzer, there's all the surface area and there's turbulence, but perhaps with a cardioform-like device, you won't create as much turbulence and perhaps minimize the risk for hemolysis. So I think when you have these IntraClip or IntraClip, MitraClip is generally the first strategy if you can grab stuff. Occluder maybe or maybe not. I think we're still trying to understand. There's such limited cases and there's such heterogeneous cases, but also not in the distant future. We're going to start seeing more and more, hearing more about clip management strategies, where you go in and either extract the clips or you kind of lacerate the leaflets, push the clips to the side, and put in a large TMVR device. So, great, thank you.
So when you put these AVP2s, I'd be curious how you put it in, because I've debated between trying to leave the waist across the residual MR, or
in between.
Or putting two sides of the disc, LA or LV. Mm-hmm. What is your approach?
Yeah, it's hard. I think wherever it's the most secure. So we've kind of done it where it's the waist is sitting in between the two clips, but the discs are on either side of the valve itself, and then there's still MR shooting through. Yeah. And you have to recapture it, pull it back a little bit, and actually cover the area where the coaptation is. Every case that we've done has been a little bit different. So I've yet to find a systematic way to plug them.